Good morning, folks, and happy Friday. Welcome to Friday Chalk Talk. Today, I've got the pleasure of introducing Alicia St. Peter, who will be leading a conversation on brain death involving its history, perceptions, our role, and other. Alicia has been in practice for 6 years as an NP, most of that time in the primary care setting before joining us here at St. Luke's. And when Alicia is away from work, she is raising chickens, along with her infamous rooster named Captain Pepperpants, whose stories have become a therapeutic part of our team rounds. The format for today will be 2 parts. We've got a presentation followed by some discussion or questions. And so, Alicia, thank you for being here with us this morning, and I will hand the mic over to you.
All right, so it's titled If I Only Had a Brain. I thought we'd start with the history of brain death, which is a relatively new idea in the medical community. It was followed by widespread use of mechanical ventilation, which prevented respiratory arrest, which then transforms the course of terminal neurological illness. There was additional urgency to better define brain death after the first organ transplant surgery took place in January of 1968. The surgeon, Dr. Shumway, came out after clearly a history-defining surgery with a heart transplant to a journalist who asked an unexpectedly difficult question, and that was the donor dead, or did you kill the donor? It was after that we recognized there needed to be a clear definition of brain death for society to accept the idea of organ harvesting. The general understanding of death is when an organism is not able to oppose inotropic forces causing disorder to maintain homeostasis. Brain death specifically needs 3 essential findings, and that's a coma, absence of brainstem reflexes, and apnea. There's a process that we know we use to determine brain death, and that includes we have to attempt to discover or get a pretty good idea of the cause of the coma, as well as be aware that it's going to be irreversible. The most common causes of brain death that we see are head injuries, hypertensive hemorrhages, and hypoxic ischemic brain insults. We then have to exclude and repair any condition that may lead to kind of confusion when doing our neurological exams. That means we'd have to reverse things such as shock, hypotension, hypothermia. We have to make sure certain drugs aren't in the patient's system that could lead to some confusion, like alcohol, sedatives, barbiturates, benzos. We would have to reverse or better understand brainstem encephalitis before we could really diagnose the patient with brain death. And then once those things are repaired and excluded, we can move on to the neuro exam. A neuro exam that would align with the diagnosis of brain death would have absence of spontaneous movement, posturing, seizure, shivering, response to any painful stimuli, no pupillary movement, no corneal or cough or gag reflex. There wouldn't be the, I think it's ocular vestibular reflex, which is when we spray that ice cold water in both ears. The clinical exam has to be completed twice and by 2 separate providers. Generally, we think that a 6-hour period of time in between is sufficient for the second to take place. And then we have to do an apneic test. This has to just happen once and happens after the second exam. And if that indicates, if all of those things kind of indicate, hey, you know, this person is brain dead, we can consider them brain dead and no additional testing would be required. But here in Western medicine, we are not always good at not utilizing all of our resources. So sometimes we do confirmatory tests to reassure the family and the medical team. So that can be a CT of the head, an MRI of the brain, an EEG. The EEG has to have absence of electrical activity for at least 30 minutes. So that gets a little hairy because there can be a lot of artifact on EEG, so that's not really the gold standard for diagnosis. Then there's the nuclear med brain scan, which would detect altered flow to the brain and help us diagnose brain death. This picture you see here on your slide is actually called the hollow skull phenomenon. Kind of eerie, but indicates that there's no perfusion to the brain, meaning brain death. So there's some statewide variations, even though the entirety of the lower 50 states recognize irreversible apnea as death. The difference kind of lies in which the states the families can disagree or opt out. New Jersey is the only state that has the religious exemption of opting out of the diagnosis of brain death. So Jahi McMath, this sweet little girl, unfortunately was declared dead in December of 2013 after a routine tonsillectomy. And she was at the hospital being monitored and ended up having a code event and not recovering. A coroner signed a death certificate after she was determined brain dead. Mom felt compelled by her faith to fight for the care of her daughter. And through legal action, she was able to transition her daughter's care to New Jersey, where she remained on life support and was taken care of most of the next 5 years in her mom's and her stepfather's apartment where they cared for her. She ended up passing from liver dysfunction and complications after that. But it's so interesting. So she was considered and signed and declared dead in California and went on to live 5 more years in New Jersey. So there are some recognized stages that we know that relatives go through when a loved one is diagnosed with brain death. Those are the initial encounter, the receipt of bad news, the confrontation of bad news, the request for organ donation, and then making decisions. So we'll kind of drill down on those. So the initial encounter and the receipt of bad news. Brain death is often a sudden, catastrophic, and unexpected event that happens to patients and their families. And as we know, families are met at the hospital with providers who have varying levels of communication skills, right? So from onset, we clinicians and the care team face the challenge of helping families cope from the impact of unexpected, devastating illness. Generally, families whose loved ones who have suffered brain death describe the initial encounter as confusing. Specifically, they're hearing from providers that things don't look good, there's little or no hope, all while families are kind of walking the halls in the ICU, right? And seeing other patients that look like their loved ones, but you're telling me that mine is dead, even though other patients have ET tubes in, other patients have dialysis and machines beeping, but you're telling me that mine is considered dead with the same appearance. So confrontation with brain death and the request for organ donation. Well, still trying to grasp the reality of what just happened, family has to now sort out the consequences for the family and their loved one. The confusion can be further bolded by seeing how the care team is behaving towards the patient. One family member saying, it was so difficult. On one hand, they're saying that my father is brain dead. And on the other hand, the staff are talking to him as if he was alive. So it's critical that we explain to the families that we intend to treat their loved ones with dignity until the very moment their physical body leaves our care. So beyond the actions, as the medical team not aligning with what we're saying to families, they can also misinterpret physical manifestations as reason to believe that their loved one is still with them. Things like spontaneous limb movement, respiratory movements, so like shoulder shrugging, back arching, and then the grasp reflex, where they get kind of excited that mom, dad, or their loved one reached and squeezed their hand. So the role of palliative care, as always, our role is to participate in effective communication regarding goals of care, aligning treatment with patient preferences and family support and planning for transitions. It's really critical in brain deaths cases to integrate an interprofessional team that allows for the expertise of a variety of clinicians and other team members to contribute to the optimal care of these families. There must be exceptional efforts made to make sense of the diagnosis of brain death because it's just wildly ambiguous. To us in Western medicine, we see it as without a brain, you're as good as dead, right? Or you might as well be dead if your brain isn't functioning. But we have to be mindful that there's other more holistically minded other traditions that might not see it that way. So the timing of goals conversations are really critical. These need to take place with the balance of straightforwardness and empathy. Prognosis should be shared honestly and carefully to address misinterpreted interaction with comatose patients. Like I said, things like the grasp reflex, so that there can be no misunderstanding. There have been some ethical arguments that no further harm can be done to a patient since the patient is already dead. Thus, the risk benefit favors allowing the family some time to continue care until they're ready to let go. This can be incredibly a very gray area because for how long? So California has a law that says a brief period of accommodation from the time that the patient is declared dead to the time that we discontinue cardiopulmonary support of the patient should be accepted. But it doesn't really indicate how long that would be. And as we know, putting off the hard can really impede on the family's ability to accept the events and begin the grieving process. Also, this is a little bit harsh, but we have to think about the insurance aspect and reimbursement. The timing of the diagnosis of brain death is put on the death certificate. So meaning after the exams are complete or the nuke med study is read, the minute that we know that that patient doesn't have perfusion to their brain and brain stem, the patient is technically dead, right? So if we wait too long, the insurance isn't going to be thrilled to be paying for the critical care of a corpse, more or less. So we are working against that clock. Palliative care interventions can help families accept death in the setting of severe neurocritically ill patients. Much of the care, much of the support will be focused on the family and the loved ones, not the patient themselves, which I think is an overarching theme in palliative care anyhow, that we're more often supporting the families than the patient. So to end with the future of brain death. So CRISPR technology, with it, we are starting to grow organs that we need for organ transplant, right? And they're far more effective because they're new and you don't have to worry about the rejection of these organs. Some speculate since there will be no need to be concerned about the quality of the organs that remain in a brain dead patient, there may be a more fluid timeline of diagnosis. So perhaps we do that to appease the loved ones that remain. The way I see it, our role as palliative care providers and clinicians won't change. We'll still have to walk alongside families, meeting them just where they're at and discussing the quality of life of their loved ones. That's it.
All right, thank you, Alicia. We'll open it up for any questions or discussion that anybody might have. And I want to add just one quick piece of commentary. When we think about public trust in healthcare or public trust in all sorts of hierarchy of power, especially in this current era, this is certainly a contentious place of brain death. I mean, there are plenty of critics out there that the concept of brain death, that there's accusations that maybe the hidden agenda is to just harvest more organs. And it certainly has allowed for more organ transplantation. I know that the public shares some of that fear. There have been public surveys out there that a minority, but still a sizable number of the population is worried that just having a donor sticker means that your doctor is not going to work as hard to try to save you, that perhaps you might be an opportunity for a transplant, for organ transplant, though I've absolutely never seen that in real practice, but it's a fear.
Hey, Marty, this is Rose. I think that the medical field has become better with putting things in place to kind of lessen that, as far as having a separate donor network, having a separate group of people who really address that stuff at that time and who are really well trained in how to interact with families. And I think that then takes the pressure off of the medical team. And so I do think we've made some good strides in that realm to kind of, allay some of those fears.
I appreciate your comments, Marty, and I agree with you, Rose. I think we've made strides. I think it just reinforces, like we talked about before, and Alicia, thanks for the talk. That's what we do in palliative care. I think it reinforces the transparency, the proactive communication with patients' families that, this is what we're about. Now, does that automatically get away completely from that distrust or that skepticism? But I think it's a big start.
What I think is tough is that we're not usually consulted on these cases, right? Because they're abrupt and things feel pretty black and white, right? We generally are only consulted in the cases where we anticipate that we might be working towards the diagnosis of brain death, right? Things are going to slowly progress, kind of limiting our reach and our ability to help. If we're not asked to be on the case, we can't be that extra support. And a lot of the focus then is going to be on the images and the exam findings, right? Like it's hard for families to see you do a brain death study, I mean, it's quite traumatic. And if somebody isn't delicate about explaining it, or it just is a really tough thing to go through.
I think you make a really good point, Alicia, that, the way a lot of the medical team probably sees it is goals are clear because it's dictated by what we see in the images, right? So we don't really need to talk about it. It just is what it is. And that can be really tough for the families who, again, like you said, this is often so sudden onset. A week ago, their life was normal. And now here they are. They've got a lot of things to talk about.
And we do have that window kind of forced on us by insurance, right? Like there is no time to waste to try and help them cope with the fact that the person that you loved so well yesterday will never be again. And also, if we could use his heart, it's just a whole lot.
Sure. Wendy, I see that you've got your hand raised.
Yeah, I just wanted to comment. I am a neurologist by background, now a palliative care doctor, and I sit on our hospital ethics committee, and me and one of my neurosurgery colleagues have revised the Freighter brain death policy, I think 3 times during my tenure on the committee. So this is a topic that's really near and dear to my heart. And I feel like I have a unique perspective, having been on the side as a neurologist in navigating brain death and families not accepting brain death, and then as a palliative physician. And I agree 100% with your approach, kind of case by case, because every scenario is a little different. And maybe I can just share a really quick anecdote. I will never forget it. I was consulted twice in the MICU as a palliative care doctor for patients that were in rooms next to each other. It was an absolutely astounding week to have compare and contrast kind of the pathway that these families go down. And when you have low health literacy or strong spiritual coping, how these two things happening side to side can feel so incredibly different. And it was so interesting to me, the support that the young man with physician parents, the kind of support that they needed and what they went through. And if I remember, he donated 7 of his organs, and it brought this like incredible meaning to that family of why this absolutely gorgeous kid would, fall into heroin addiction and make some meaning of that. And then the other group, the family never came to acceptance of the brain death, really. It was forced upon them, ethics, and then, a scheduled date for removal of the ventilator. So I guess I have learned over years and years that we need our chaplains, that one of the roles of the palliative team, I think, is really to engage in that type of conversation and that type of meeting people where they're at, as opposed to forcing. And then just the final piece, because I'm talking too much, the final piece is for that young woman. She survived brain death for several years, and she was declared brain dead by, I think, 3 neurologists. So all of it just gives you pause. Thank you for your presentation.
Wendy, I am so glad that I found out after the presentation that you are a neurologist, because I was nervous to start. So now that I know you are here, holy smokes, no pressure.
You did great. You did great. Not at all.
So Wendy, I appreciate your that you recognize the need for chaplains, and I would love to hear you say specifically how do we help in these situations? What is it that you've seen?
Yeah, I mean, it's tough, and every case has a different spin. But this particular case that I shared that was so memorable, we actually met alone as a palliative, because there was such a division between the ICU team and the family before we were ever involved. And we met alone with them and sat with them for some time to really get at where they were at and their understanding and what their beliefs were. And there was an incredible need to acknowledge, God's work in his care. The way they saw it is that he didn't die initially from his injuries because he came here to the hospital. And when he did, we did all these things, right? And the way he looked physically didn't change, but suddenly the team said, no, we're done, because he's brain dead. And so it was a process that went over a period of days. We involved our ethics committee because we have a policy that talks about allowing for time for the family and sort of an approach when family is not accepting the brain death diagnosis. And like I say, it never really resolved itself. But what we did is we brought in a lot of, spiritual support. We brought in a patient relations person we have who's wonderful, and did a lot of walking with the family, honoring their wishes and wanting a miracle. And then there was a scheduled time for withdrawal of the ventilator.
Thank you. Kim, I see that your hand is up as well.
Thank you. Excellent presentation, and especially stressing the nuances of consistent communication, because that's what confuses the families most. But I wanted to make a comment about surviving brain death. So the physiology of what we see. So my background is pediatric intensivist before I transitioned into palliative and hospice. So unfortunately, I worked in a trauma center, Mount Sinai in Chicago. So I dealt with this more frequently than anyone would want to. But what you see is that if you test within the first 2 to 3 days when brain edema is maximal, then you can get testing that shows lack of flow. But if you wait and you're testing on day 4, 5, 6, or further out, when the cerebral edema has resolved, then flow will start to trickle in. And so then you can't declare a patient brain dead at that time, unfortunately. And so patients may survive, but survival does not equate to a quality of life for a lot of these patients. And I had one mother who came back after her son really survived for years and said that there are really some things worse than death. So we just have to be cautious when we talk about survival and what that means for families, for longevity. But the physiology is if you test early, then there will be no flow. And if you wait until cerebral edema is resolved, you may have some flow trickle in, but may not be meaningful.
Thank you. And Rachel, I see that you've got one question. I think we'll make this the last question of the day.
Alicia, I wanted to clarify. Did you say that a family in Rhode Island just decided that they would not accept brain death because of their religion?
So it was Jahi. I was a little girl in 2013 in California who had coded after a routine tonsillectomy, and mom wasn't agreeable to the diagnosis. So she actually transitioned her care after legal pursuit to New Jersey, because New Jersey is the only state where you can have the religious exemption to exempt out of brain death, right? The brain death diagnosis and what that means. So that's what she did. She took her baby to New Jersey and took a trach vent kiddo who was brain dead and cared for her at the apartment there for 5 more years.
Okay, I wanted to clarify because it seemed really surprising that someone could, well, and I guess I'm not so surprised as of late by what the government has decided what is allowed and not allowed. There was a judge in Ohio who decided that ivermectin can be given for COVID. I don't know if anybody heard about that. So interesting things, but it was surprising to me that a family could basically negate medical expertise and say, nope, we're not accepting this, and we're going to do our own thing. Just astounding. And I wonder,
Rachel, I think it's interesting that you think that, because maybe not on the grand scale of getting on a plane, but I think we see that every day where patients are just like, I hear what you're saying. I see the studies, but I'm certain that's not true, but this is like such more of a grand scale.
Yeah.
Well, and this is Rose. How is that different than obtaining a second opinion?
Absolutely.
And we
Yeah,
have families.
That's valid.
I had families refuse. You may have read it in the news. At one point, we had a father who threatened us at gunpoint. That even though the child was declared brain dead, that if we withdrew support, that some of us were going to go with the child. So families, it was very difficult. We had families refuse all the time, and that's where communication comes to play, and consistent communication with the family. It's hard for even the staff to see a perfectly normal or a healthy looking person sitting there when it's related to a trauma. My most traumatic one was a child whose spinal cord was transected. She was riding in the car, it was an accident, spinal cord transected by the seatbelt. So she looked perfectly normal on the outside, unless you looked at her imaging. So it's difficult for patients, family, and the staff caring.
And as a former peds ICU nurse and seeing brain death in the pediatric world, there are no words. Like, it's so hard to walk alongside them and explain, like, it's a matter of, we could keep your baby alive, but they will never play on a playground, right? Like, those conversations are so different.
All right. Thank you so much, Alicia. Thank you, everybody, for all your viewpoints. Clearly a complicated subject, as are most things in medicine. That's why we work in palliative care. We like the gray area, right? All right, folks, have a wonderful weekend. Thanks for being here.